We're going to, some of the speakers that you've just heard, we're going to move over here for a panel discussion. And as I mentioned, you will have the chance to ask questions. So if you think of a question just towards the end, raise your hand and we'll try to get round to as many of you as possible. But if I can ask Professor David Thomas, Caitlin Delaney, Associate Professor Vanessa Tyrell, Tiffany Boughtwood and Jane Tiller to come up. Give them all a round of applause. Welcome. Don't forget, be thinking about your questions as we go through. So I'm just going to start with David. Just, you talked about the different programs that you're running, but in simple terms for people who might not know, if you're diagnosed with cancer, who qualifies to have their tumour sequenced? Does everybody get that opportunity?
So there are, our goal is for every cancer patient who's facing an incurable condition, which is 50,000 people who lose their lives every year in Australia, gets access to profiling at a time when it makes a difference to their treatment. The program that we started off with, the MOST program, which has got to 7,000, 8,000 odd patients, was for patients in the terminal phases of their illness who'd run out of treatment options. We've learned from that because so many patients were on that black line that I showed earlier. We need to have them, we need to get earlier in the cancer journey for sure to be able to maximise the value to patients. So now it's first-line metastatic disease, incurable, and first-line incurable disease. As soon as that diagnosis is made, we want to be able to profile. And our resources allow us, in principle, to screen about 20, at peak flow, 20%, 1 in 5 cancer patients who really need it. So we're still not there yet, but it was 4% 5 years ago. It's now 20%. The idea is, we're trying to work out the resources, how to bring together the resources to be able to get it to everyone.
And I'm interested, we've been talking a lot about the situation in Australia, obviously, because that's where we are, about how we compare to other countries around the world. And, we know, for example, the UK is streets ahead of us. So maybe David and who else, Jane and whoever else wants to jump in, or Vanessa, about how does Australia stack up when it comes to other countries in genomics? Are we really far behind the 8 ball?
I actually don't think so in the cancer space. The UK, through David Cameron's Genome England project, provided whole genome sequencing for 100,000 Englishmen and women and children. But actually only about something of the order of 5,000 or 10,000 of those actually had cancer. And they hadn't done the trick about connecting with industry systematically to provide treatments because it was taken out of the NHS. And that's proven to be one of the learnings out of Genome England. Whereas what we're trying to do is integrate it into the healthcare system so you can treat patients. That's,
Vanessa, is there anything you want to add there?
Yeah, so with Zero Childhood Cancer, we started out behind, but then we were leapfrogging because we decided very early to go big or go home. We wanted to go straight to whole genome sequencing and whole transcriptome sequencing. And so we did that. What we found was that allowed us to catch up with the rest of the world and really lead the way in that respect. We now have a lot of the precision medicine programs for children around the world who are following in our footsteps. Having said that, in the UK, whole genome sequencing is now provided through the NHS for children with cancer. And we're seeing that, and we collaborate with many of these precision medicine programs around the world for children. And we're seeing that it's been integrated into the German, the Netherlands health systems, the French also, and we collaborate very closely with the Canadian equivalent Profile, who are also working towards that right now as well. So we're really seeing everybody catch up and the health system starting to take over. We're still sitting in the research environment.
And Tiff, and then I'll go to Caitlin to talk about patients after that.
Yeah, thanks, Sophie. So certainly NHS England has a very ambitious genomic medicine strategy, and it's certainly championed by Sue Hill. The challenge they have is the implementation. So they're trying to increase capacity to be able to provide comprehensive cancer profiling to patients with advanced disease. And the challenge then is providing results in a meaningful time frame. So it's all that scaling aspect. So Sue driving it by hook or by crook, seeing the patients, the advantages delivered to the patients is another story altogether. And that's really what I think we're seeing in the UK.
And Caitlin, from your point of view, you said patients contact you. Do patients from around the world also contact you about their experiences? Are there any good experiences overseas that we could look to say we should be doing what they're doing?
Well, it's the oncologist that I see in Singapore. So he's my third opinion oncologist. And he's also a scientist and a professor. So he runs a lot of clinical trials, and he was associated with the clinical trial here. So it's more that I take information from him, and that's how I ended up being on that treatment that kept me stable. But he's then presented my data at Berlin, a conference in Berlin, in the UK, in Singapore, and then he's connected me to patients in Australia that have reached out to him. So it's not so much that I just go through him, I trust him implicitly, and then there's other patients then contact me who want to know what I've been on and what I've been doing. Yeah.
So one of the things that the report, getting back to the report, what the report calls for is it looks at the issue of genetic discrimination, which you've heard a bit about this morning. So Jane, I wanted to go to you. One of the issues and the things that the report calls for is making sure life insurers can't access genetic information. Why is that so important?
It's very important, and I touched on it briefly, but we've really shown over the last decades, and especially in the last few years, the impact that it has on people taking up genetic testing. So we have to tell people in every consultation, every research consent form, every time someone considers having a genetic test, we have to say to them, before you do this, have you considered the insurance implications? And many people will say, well, no, I haven't, but now that I have, I don't want to risk that. I don't want to risk my financial future or my children's financial future. Maybe I'd rather not have this information. Maybe I won't get the genetic test so that I can preserve my life insurance. And that is an absolute tragedy. Many other countries, bringing it back to your last question about where we benchmark in the rest of the world, many other countries have banned this. This isn't something that we're asking Australia to do that's out of the ordinary. The UK, since 2001, has had an agreement between industry and government that they won't use genetic results to discriminate, with a very small exception. Canada passed criminal legislation in 2017 that banned all entities, including insurers, from asking for or using genetic results. And so it's something that is absolutely critical for protecting consumers, for allowing them to make decisions on the basis of their medical needs and not about financial fears, and to make sure that we can move forward with trust in genomics and allow people to have that testing and put insurance to the side.
Okay. Did you want to say something, Tiff?
I can always say something. But just particularly, I think, to Jane's point, and also the study she's been leading around DNA screening, the adult cancer risk screening, when we're moving, we're hoping that healthcare moves from diagnosis and management into identification of risk and prevention. And that's the context that issues like insurance discrimination is going to stop population uptake of the power of genomics, and it's going to prohibit the evolution of healthcare to really take advantage of this technology.
So Caitlin, can I go to you? You mentioned the concept of sliding door moments in your journey. In the moments that really shaped where you are now, can you take the audience through, elaborate a bit on those moments, particularly the ones that relate to genomics?
Yeah, I think the one that stands out for me is when I recurred. Actually, if I go back to the beginning, no one really believed I was clear cell pathology because I had such a good response to chemotherapy initially, which clear cell can get resistant to chemotherapy quite quickly. And so everyone just assumed I had the I'm having a brain moment, sorry, high-grade serous ovarian cancer, which is a more common one. So no one really wanted to treat me like I was clear cell at that initial onset. And I look back in hindsight and think, if I had known I had a HRD mutation back then, would I have been given a PARP inhibitor frontline and maybe never recurred? But because, there's no point going back, that's what happened. But there was all this thing of it doesn't really matter what pathology you are, we'll just treat them all the same. And even though I was NED at the time, I knew I needed to know, I needed to push for genetic testing and work out. And then they're like, oh yeah, you definitely are clear cell, and your HRD and ATM mutation, that's not normally connected to that. But by having that information from the tumour, that genomics, I was able to then, when I recurred and I was resistant to chemo, say to these other doctors and experts, what do you do? And I had about 10 oncologists that were looking at my case. They were all excited because it was really an anomaly. And that was enabled me to get that off-label drug. So I think that's the biggest moment for me, was having that data and saying, what do I do next? And the issue was having no clinical trials. They're a few years away, like you've all pointed out. And I thought, well, I don't have a few years. My children are so young. I don't have that time. And they're all saying, well, this new drug combo is meant to work, but it's a few years off and there's no trial open. And even if there was, I'm normally not eligible because of my pathology. It's normally for the high-grade serous. So this is the thing. I know we're all promoting clinical trials and they're fantastic. But there needs to be also a safety net for those that I need to be in a VEGF inhibitor for life. If I've got a clinical trial, I won't be able to be on that if it doesn't include a VEGF inhibitor. So having this off-label treatment access allowed me to be creative and actually have the drugs I needed to have.
So obviously you've got a scientific background, but how challenging was it to have to advocate for your own health while dealing with a serious illness, a life-limiting illness?
Oh, I mean, I'm not a research scientist. I'm an IVF scientist. I'm not a cancer research scientist. And you can't even do a lit review because you are the centre of that trauma. You're reading like progression-free survival and going, oh, okay, that gives me 3 months. And then it's not good for your mental health. It's very hard to unpack it. I can't do that. And I don't have the skill set to do a reliable lit review with all the data. I need to trust my medical team. But that's very difficult when they're not across the latest science. And yeah, so I don't know how other people do it. I find it exhausting. I normally have a breakdown every time I progress because I'm like, well, what do I do next? I don't know what to do. Yeah.
No, it would be challenging. And David, do you mind sharing with the audience a bit about your journey as well, from doctor to patient, and all your knowledge, and how that helped, or was it a help for you to?
Well, so I've got metastatic prostate cancer. I'm fortunate enough to have metastatic prostate cancer. The treatments that have been developed over the past 10 years are really quite remarkably effective and benefiting from science. It didn't really change my perspective one iota, and I think that's because I've been looking after people like Caitlin for so many years. Everything that we did was oriented, ultimately had to make sense right down at the point where you're discussing something with the patient. The fact that I was on the other side of the desk didn't really, it just meant that the logic held, thankfully. Imagine if I'd crossed the other side of the desk and thought, what are you doing?
All these years I've been doing it the wrong way.
That's right.
So it validated that the approach that you'd been taking, looking after other patients, was the right one.
Yeah, I think so. And it just reinforces the message about how fast science is advancing. It makes me very passionate. I mean, the argument here is science is fantastic. It's clearly making breakthroughs that are extending our lives. We want it to go faster, and we want to have more access to it. That's what we want. It's logical that was what we want. Only 7% of people take part in clinical trials. Imagine if it was 70%. How much faster would knowledge progress? Just leaving aside the benefits to the immediate patients or the front line coming onto those trials and making advances, imagine what things will look like in 5 years' time. Would you compress the time frames even further? My instinct after 30 years as a doctor, 35 years as a doctor, 25 as an oncologist, is that it's credible that by 2050, the 5-year survival from cancer will be in excess of 80%. It was 25% in 1970. It's 70% in Australia today. There's no reason, if we can't push the envelope, that it shouldn't rise higher. And if we also include public health approaches to early detection, risk stratified, personalised risk management and early detection.
And David, do you believe that genomics and the genomics revolution that we're talking about today will get us to that higher survival rate that we're hoping for?
It's part of the puzzle.
As well as the better uptake of the early detection and screening?
Yes, so it's...
Don't throw out your bowel cancer kits when you get them in the mail.
No, it's absolutely right. But, we screen every woman at the age of 50 every 2 years with a mammogram. Some of those women are never going to get breast cancer. We know that from polygenic risk scores that put them at the lower end of risk. Others are very high risk. We should be screening them at 40. You can use the same resource more sensibly if you can target your resources. That's one element to it. But it's not just about genomics. It's about a molecular view of a disease that gives you, it's like the Enlightenment. The reason why our lifetimes are extended is because science entered in the age of enlightenment. We had a rational view of the world. Science became a part of the way that we did everything. And that's why our lifespans are what they are today over a 30-year period after being 35 years for tens of thousands of years. So we're just getting that Enlightenment model applied to cancer in the past 20 years. And it involves... It's not just genomics, it's protein-based targets. The antibody-drug conjugates are working on HER2-positive breast cancers and other cancers, which don't have amplification we can genomics, but it's still a biomarker. It's about a molecular framework. It's about a research-led model for care that's integrated into care. And it's not a sustainable thing if you did it globally, because ultimately somebody has to pay for the advances of science. But we're right at the cusp of being able to be true innovators as an ecosystem. And I think that's what we must seize advantage of now if we're to maximise the benefit for all of us.
So one of the recommendations in the report, in fact, it's the first recommendation, is to have a national genomic strategy with genetic testing as standard of care for all patients in Australia. So I want to ask the panel, what difference do you think that would make if we can convince governments to introduce that? We'll start with Tiff.
Okay. Look, I think certainly, the observations that David's just made about, when genomic testing was available to patients and the implications it had, it's not extending, life for a few months when, much of their hope is gone. It's looking at risk profiling and identification of potential targets early on in that cancer journey. I think that's a real sort of fundamental shift. But also thinking about the way, from a policy perspective, we gather evidence, we consider value of an implementation. It has to be systemic. It's not just the test itself.
And Vanessa?
Agree with Tiff entirely. And I think in terms of what it really means, you heard me talking about treating early and how we could potentially actually avoid relapse or progression if we're getting the right treatments to patients at the right time,
rather
early
than waiting
on.
Until they've failed a number of
That's
treatments.
Right.
And
Yeah. So I think that's really critical. And then I think the other area that's really critical that we're really only just starting to understand, particularly from paediatrics, is that burden of cancer predisposition for the children. And you think about it and you think, well, that's logical. They're little kids. They haven't been exposed to the toxic environment that we have as adults. So what's really happening there? And if we could do that earlier, if we could understand that earlier, if we could start surveillance and risk reduction early, then we'd be going a long way to the holy grail, which is prevention and control.
And David, what would you see as the main benefits if we do get a national genomics strategy?
Well, it recognises that every part of the ecosystem is affected by that model and starts to harness it rather than have it sort of stochastically, sort of Brownian motion. It's at the moment it feels as though it needs a coordinated approach to get the best value and to reduce costs. I think we have to be accountable for sustainability because there are many worthy causes.
That was one of the words that the minister used. I wrote them down on a different piece of paper, but sustainable was definitely one of the words he used.
And equity.
And equity. Caitlin, what would it mean for you if we can get governments on board and have that national genomics strategy? What do you think it would mean for patients, current ones and future ones?
Well, yeah, as a patient advocate, I agree with everything everyone's saying, and equity is the big one. And I'm talking to people all the time that are being offered a biopsy post-chemo. The cancer cells are dead after the chemo. So then they're like, oh, we've got nothing to send for. Well, why weren't they offered that before they had the chemo? So there's just no consistency. And to be fair, oncologists are super busy. And there needs to be, if there's a strategy at a national level, then it levels the playing field. And that everyone then gets information and gets educated and gets upskilled. And I think that's really important so that we can make sure that we capture everybody in all parts of Australia.
and Jane, and then I'm going to go to the audience. So just raise your hand if you have a question and we'll get the microphone to you while Jane answers. There's one, a question down here.
So the importance of that strategy is that genomics underlies everything. And, you know, we're starting to realise this. We're starting to see that it's tumour profiling, it's testing for, you know, what drugs are more effective, it's therapies, and it's also, as even in children, as Vanessa was saying, far more than we expected, where we're finding a predisposition, something that's impacting other generations. We didn't expect that childhood cancer would be the, you know, the way that we would find cascade cases, for example. There are so many ways that we use genetics, and so many health professionals still in the space who don't even understand that genetics is important. You know, it's still seen as something over there that has nothing to do with what they're doing. And we have to move out of that. And along with that, we have to look at the bigger picture, and we have to realise that as soon as we do that, we need all the associated care services. We can't just fund testing.
That's just the first
we have
step.
to fund the whole picture.
So we've got a question along here. Here we go. And just raise your hand. We'll try to get, it's very bright, but we'll try to find you and get a microphone to you.
I have a question for Vanessa and David. Regional and remote communities, how do you go with capturing patients from those areas in both the Zero Childhood and in the MOST and aspiration trials, any of those?
So from a kid's perspective, we're quite fortunate in that it's a finite number of children. And also every child who's diagnosed with cancer comes into one of the 9 paediatric oncology centres around the country at the children's hospitals that are generally teaching hospitals. But what I would say to that is that we still face challenges, particularly from the culturally and linguistically diverse and the Aboriginal and Torres Strait Islander communities. And that is something that we're really focused on now, that and I will say that it's taken us a long time to get there, because we've been focused on just trying to get Zero open to or be available to every child. And so our focus now is looking at how do we create a program or a study that's the same as what we're offering with Zero, but something that works and is accessible for those communities. And that's something that we're starting with now with our colleagues in the Aboriginal and Torres Strait Islander research space, to be able to do that with the ethics that's required on that front. It's quite a journey.
David, from your point of view, how do you manage with regional and rural patients wanting to take part?
So cancer survival is lower in regional rural Australia. Cancer survival is demonstrably worse in Indigenous patients. We have a proactive program. So we've expanded from 23 centres in the past 12 months to 43 centres, and we've specifically opened partnerships in what I call the Ring of Steel between the major cities along the eastern seaboard in particular, all the way from Townsville through Coffs, Macquarie and inland, all the way to southeastern South Australia. And the reason for doing that is that we want the oncologists in those areas not to have patients travel to get the test done. There's no reason for a patient with metastatic disease to travel for a test. And increasingly what we're trying to do is open trials at those centres. And I think there's a real opportunity there. I actually think regional cancer centres will outperform metro cancer centres per capita in enrolment on trials. And if that model works, I mentioned the relationship with the sites before, if that model works, then it may mean that we'll be able to deliver treatments out remotely. There's a tension. I just want to acknowledge a tension. Specialisation of resources gets concentration of expertise, but you can have a hybrid mixed model. And there's the Teletrials Initiative and other approaches that the government's invested in that will see us be able to look after people remotely safely without them having to travel at a difficult time of their lives.
That sounds great. So just raise your hand. If you do have any other questions, we've got a question here. Yep, let's go to that one.
Hi, Joshua from the London agency. My question is probably to David and Caitlin. Obviously, there's a lot of people who are quite activated as patients, especially like yourself. How do you, as a HCP, kind of motivate somebody to be the activated patient? And then what, on the patient side, what kind of inspired you to kind of be that active advocate for your health?
So Caitlin, do you want to start? What encouraged you or what motivated you to speak out and become a patient advocate? And then David will go to you about how do you encourage your patients to become advocates?
Yeah, I think it was, as having that healthcare background, I always was very passionate about the patient experience and thought had quite a good rapport with my patients. And then I didn't realise until I was a patient myself that I just suddenly didn't feel confident that I could speak up. And I'm quite an assertive, confident person. And there were times where I didn't want to upset doctors, or I didn't want to, you feel very powerless. There's a power dynamic at play in a room. And I think it was just the fact that I had 2 children, one still in nappies and not yet at school, and a lovely husband. And I thought, I'm not done yet. No one tells me when I'm dying. Nope. So I'm also stubborn. And I just unfortunately lost my mother-in-law due to medical negligence. And I think I grew cancer just after she passed away. So I did see that sometimes the healthcare system could break down. So I lost a bit of trust at that point. And I was not long after she passed away, I got diagnosed. So I realised, oh my goodness, I can't have what happened to her. I just have to be on it. And for the most part, I've had a fantastic care. So I just wanted, for the record, to say I'm not here whinging about the care I've had. I've got an analytical mind, and I'm just seeing lots of gaps. And so the second part, motivating the other patients. So with my business Carefully, I help healthcare professionals to support them to have this really good communication and compassion. But I would love to expand that to be able to help to empower patients. I do that more on an ad hoc. But I use this space, even though it's hard getting up and sharing your story and being vulnerable, because I want to pay it forward. Because I want to tell some patients it's not going to be hope for everyone, but sometimes you just have to seek another question, another answer. And I feel like a responsibility, to be honest, that I have to do that.
And David, what about you? I guess there's a fine line as a healthcare professional. You might want your patients to speak out, but your number one goal, I guess, is looking after them and protecting them, while you still might want to encourage them to advocate?
Yes. I mean, there are different people with talents in all sorts of ways. Firstly, I wouldn't undersell the intellectual contribution made by all sorts of very diverse patients thinking about a problem. It was my experience in the sarcoma space that we would have to jointly work out what to go. I mean, I'm sorry about the whole, we're not sure what to do here, but if you say that, then you can start to say, well, we have to act, so let's come up with a solution. And I've found my patients have often given me really good ideas, or priorities, if you like, about how to manage things. And that's probably true at a systems level. So on the board of our non-profit organisation, we have captains of industry, very able people from public sector, who've actually made all of what you've seen possible. It's not just clever academics and clinicians. It's actually really minds thinking about society as a whole. And I think also, I would say, I've always been impressed. Patients don't, and I know this is true now, don't expect miracles, but they want you to have a go. And have a go. Show that you're prepared to, come up with something that's reasonable. And I think that there's a degree of altruism in taking part in these sorts of activities, which is deeply embedded in what people do it for their own sake, but they also do it for other people. And that's remarkable. That's one of the great privileges of being a doctor, is how many people in the crucible of facing a life-threatening illness have been generous. And I guess then the circular, how can you resist trying to pay that back as well?
Tiffany?
Just quickly, and sort of expanding on Nessa's point too. I mean, so many of the advocates we're hearing from today, are eloquent and passionate and really driving their own sort of, cancer management trajectory. And I think we should consider those for whom English is not a first or even second language. The clinical system is not geared or well suited to their journey in the first place. Or there might be a power imbalance, or there might be an intrinsic lack of trust. And I think organisations like Rare Cancers are so critical in that context to provide the advocacy for patients who are just unwilling or unable to advocate for themselves.
Yeah, good point. Look, we're actually getting a sign saying time's up. So this time's absolutely flown. I don't want to get in trouble from Natalie, who's running today. So look, thank you. Everyone give the panel a big round of applause. Thank you so much.